Hello, I'm Dr. Israel Barkin, the Medical Director of the Prostate Cancer Research and Education Foundation. Every Tuesday, 6 p.m. Pacific Time, we have Ask Dr. Barkin call-in show. During the show, we discuss some articles, and now I'm going to present one of the articles that will be brought up on March 8, 2011. Let's go now to the first article. Early development of castrate-resistant varies with different dosing regimen of luteinizing hormone-releasing hormone agonist in primary hormonal therapy for prostate cancer. This is the LHRH agonist, which is the Lupron, which is being given to patients as a primary treatment for the prostate cancer disease. These are patients that do not have any surgery, radiation, or any other procedure on their prostate. So let's go now and see what is this study all about. The objective of the study were, one, to look at 3 dosing regimens that currently exist. The first one is calendar-based. That means every 3 months or every 6 months or every year, and it goes according to the calendar. The second regimen is intermittent, which you give the patient a period of time, the hormonal blockade, and then you stop, and then there is a holiday or vacation from the treatment, and then it's being decided to restart it again. Usually the PSA is the indicator when to restart, and in some cases when to stop, and there are different formulas. There is still no clear information which is the right way to do it. And here is the third, the newer approach presented by these authors of this article. This approach takes the testosterone as the measurement telling the doctor whether to give the hormonal blockade or not. The testosterone is supposed to be kept at a castrate level below 50 nanogram per deciliter, and according to that, in previous experimentation, the mean period of time was like 6 months, giving the Lupron about every 6 months. They investigated the difference in development of early castrate resistant rates between these different regimens. The methods: they took 1,617 patients, and they received Lupron monotherapy between January 2003 and December 2006. The patients who had surgery or radiation were excluded. Patients that also were on combined hormonal blockade were excluded. These are patients that were only on Lupron. Patients were grouped according to their dosing regimen, either according to the calendar, every 3 months, or every 6 months, or every year, and intermittent, on and off treatments, and T-based, testosterone-based, the starting and stopping according to the level of the testosterone that had to be maintained at a castrate level. The results: a total of 692 patients who received an LHRH agonist, the Lupron, as primary monotherapy. They fit the criteria. They had 3 groups created. The calendar-based were 325, the testosterone-based were 252 patients, and the intermittent blockade, there were 115 patients. The testosterone-based dosing group showed a significantly lower relative risk of treatment failure. That means they had lower risk of becoming hormone refractory or castration resistant. The intermittent dosing group tended towards a lower risk treatment failure, but it was not statistically significant, although it showed a trend. Among the variables analyzed, only glycine more than 8 and level of PSA were found to be associated with higher risk of treatment failure. Conclusion: during the time period studied, the testosterone-based and intermittent dosing regimen of Lupron had lower rates of early castrate resistance compared with the standard calendar dosing based on measurement of early androgen resistance. Thank you very much for listening. Please join us every Tuesday, 6 p.m. Pacific Time. you could dial 1-877-727-3301 or get on our website www.pcref.org, and from the home page at the time of the show you could listen to audio stream, or you could download the show on your computer or on your iPod. Thank you for listening. Goodbye.